things. Who wants to be the first one? Oh, I see this hand.
Hi, I'm Sharon, and I had my surgery 9 years ago. Sleep problems have been something that's recurrent with just about everybody. Because so much of my large intestine is gone and resection has occurred in my small intestine, absorption is a problem. And absorption of vitamins and minerals, etc. Has there any work been done on how lack of absorption of minerals, etc., affects sleep?
Does anybody want to take us?
You have asked an excellent question. For which I have a substandard answer. Not much. I don't think it's the minerals. Usually you can get enough minerals in. The problems that most people have after losing a lot of gut is having to get up in the night and go to the bathroom. There's no magic treatment for that. Sometimes you can change your dietary schedule and move things like that. Minerals per se are not usually a problem. You can do those are usually checked for with most routine blood tests. So, like I say, you're asking an excellent question. The answer is, as far as I know, no. But I don't know that that's going to make you feel a whole lot better. Some of it's going to be about what. Sometimes you may need more minerals of various types. And I'd have to look over your chart and see exactly what part of what was removed in order to give you anything more specific than that.
Does someone else have a question?
Just let me make a comment on this. What wakes you up? What is it that wakes you up? I'm sorry, I didn't hear what woke you up. With the bathroom. Okay. Some of that page that you saw with Dr. Duckworth, but it has some tips on with other factors, not necessarily with the going to the bathroom, which is a secondary form of insomnia. But you can try those tips, and sleep patterns are very hard to change, whether or not they're interrupted by your own rumination or an external event. But if you had to change one thing in your life that could influence this, be total darkness and no screens within an hour before you go to bed, TV, computer, at least an hour before you go to bed. So while this may not influence your going to the bathroom, it might affect other factors that could contribute to helping you sleep.
My name's Neil. The procedure that you talked about that originated in Australia, the two elements involved with that are fairly common. I can go to my local drugstore and get them. So without divulging trade secrets, how are you applying those two chemicals in a different way than I could do it myself?
I think there's a couple of things. Number one, you have to get pharmaceutical grade reagents in. So this is just for everybody else. This is a research study. So this is not for everybody at all times. We're trying to dissolve mucin for people who've got large collections of them. And the concoction, which was come up with in Australia, uses bromelain, which is an enzyme you get from pineapples, and N-acetylcysteine, which is a common drug or chemical we use for all kinds of things medically, which is readily available. What you have to do to do it yourself, you have to inject it into where the spot is, leave a catheter in at least overnight, inject the material, and then let it drain out. To say the least, I wouldn't recommend just poking yourself and hoping you know where this is. The truth is, there is no question in my mind, just in case you may happen to be a chemical engineer, that you can probably get the concoction and mix it together. The other problem is getting drug-grade bromelain turns out to be a big deal. You have to be able to purify it, get all the rest of the pineapple-y stuff out of it, and just use the enzyme alone. And getting something that you can inject that isn't going to have contaminants from last week's dinner with your pineapple is actually more of a challenge than you might guess. So can you do it on your own? Not recommended. Not recommended. Kids, don't try this at home. But the basic principle, though, is as you grasp. The basic principle is so ridiculously simple, it's hard not to be attractive. Pineapple smoothie will not do it. You've heard it. And you have heard that from a professional nutritionist. It may not hurt to try. I heard that. That's good.
Hello, my name is Pam, and I want to thank you so much for bringing all this great information to us. I appreciate your time. One of the things that I seem to see some discrepancy is surveillance after surgery. So I wanted to get a better understanding of, in terms of CT scans, blood tests, what are you prescribing, and I just noticed that some doctors are a little, they vary in terms of surveillance. And I actually have another question, and it's about adhesions, and if there's a way that, or any study or any, seems like I read somewhere where there was ibuprofen was helpful in reducing adhesions. I don't know exactly where I got that information. It was somewhere on the internet. But I just wanted to get your opinion on surveillance and adhesions post-surgery.
Sure. Let me get the second question first because that's a lot easier. There's only a few things that can help minimize adhesions other than doing quality surgery. There's some films you can put in the abdomen that will cut down adhesions by about a third. And you might ask, why don't we use these all the time? And the answer is because they cost $10,000 to throw. They eventually come on with they're trying to come up with something you can spray on the bowel to keep it from sticking to each other. So as for now, there isn't a whole lot you can do. Once you have the adhesions, there's nothing you can do, really. You can learn to live with them, but there's no medication that I know of that will get rid of them. Motrin or ibuprofen will not get rid of adhesions. I can tell you that with ridiculous certainty. Okay, that's easy. Now, for number 2, which was your first question, surveillance. You also have asked a great question. The answer turns out to be a little complicated. So if you're going to be following up, and we're just talking about cancer of the appendix, the follow-up is going to typically consist of blood tests, imaging, and physical examinations. How often should it be done? This is varied depending on where you are and where you live and what grade you have. If you have a low-grade tumor, my follow-up schedule is twice a year visits, physical examination, blood work, and scan. Scan being either a CT scan or an MRI. Both of them work. And nobody wants to have any scans, of course. But the real question between a CT or an MR, in my mind, is would you rather have radiation and some IV things that can hurt your kidney, or would you rather have a magnet scan with something that's going to deposit a heavy metal in your brain? Those are the choices, because the MRI will give you the heavy metal in the brain, and the CT scan is going to give you some radiation treatment. Having said that, they're both very safe. So do you need to be scanned more than that? Having said that, you don't want either of them now, I can see that. Seriously, CAT scan or MRI, either one is fine. If you've had a lot of CAT scans before, I would continue getting CAT scans. If you had MRIs before, get MRIs. It's nice to compare apples to apples as opposed to CT scans to MRs and up and back. The blood test that you get, there's some blood work that comes with it, and there's 3 tumor markers we usually use: CEA, CA19-9, and CA125. I'll always check those before the first operation. If the levels are normal, not everybody's tumor produces these markers. If your tumor doesn't produce those markers, there's no reason to follow to follow along looking for them afterwards. If the tumor does produce those markers and it falls from an elevated level to a normal level, then you can follow that over time, and it gives you a rough idea if there's tumor coming back. It doesn't correlate crisply with how much tumor there is, but that's one way you can follow up. It's also useful for the medical oncologists. If you're going to get chemotherapy, that's something else you can follow. What you don't want to do is too many follow-up scans, because it does a couple of things. Number one, if you have too many follow-up scans, you wind up seeing Dr. McQuellon, because every time you get a CAT scan, it's going to make you nervous. Every follow-up scan I've ever had for every patient I've ever cared for with this disease, when CAT scan time comes, your pulse rate's going to go up 10 points, you're going to be nervous, and you're going to be saying, am I going to be seeing the grim-faced doctor you heard about before, or am I going to get the thumbs up? And you don't know, and you can't tell. So it wears you down. And most of these tumors, particularly the low-grade tumors, just don't come back that fast. They tend to be more slowly progressive. High-grade tumors, even then, twice a year is probably enough, no more than 3 times a year. Some people will follow these particular diagnoses every 3 months. I think that's way too much. I mean, unless you've got some sort of ongoing treatment going. So, and now the farther out you get from the treatment, the less often you have to have your scans. Most of the recurrences are in the first 3 years. Although I've seen these cancers come back 17 years later, most of the recurrences are in the first few years if you're going to have one. If you're free of disease after 3 years, you can probably go to a once-a-year scan. Having said that, if you had this disease and you lived in England, the English follow-up schedule is once-a-year visits with a scan. That's it. That's all they do. Yes, ma'am. How many? I'll tell you the way I do it. And as was suggested, this schedule is going to vary pretty widely. So every 6 months for the first 3 years, if things look good, then year 4, 5, 6, 8, and 10. If you're still looking good 10 years later and everything's clean, we'll cut you loose. That's one of my favorite visits, by the way. I love the cut you loose visit after 10 years.
Is there any other questions on the other side of the room here? We've heard on the right side. She's bringing you a microphone right now.
So I've noticed on the PMP boards that our friends in England without a spleen get antibiotics all the time. What is the finding on that?
Not recommended. The best way to manage, if you have your spleen out, the spleen it's got some immune functions. It does a lot of things in terms of metabolizing red cells and platelets and that sort of thing. But there are some specific bacteria the spleen filters for, particularly what they call encapsulated bacteria. And if you don't have a spleen, you are predisposed to something called OPSS. I know we've had a lot of abbreviations today. That is overwhelming post-splenectomy sepsis, which means you can get really sick really fast and go from walking around feeling great to in the ICU, really sick on big-time antibiotics in the course of 24 to 36 hours if you are infected with one of those specific types of bacteria. So what do you do? First of all, the OPSS is rare in adults. You see it almost exclusively in children. The chance of developing a case is in the 1 in 10,000 range after a splenectomy. What we do in the States is, rather than keep people on antibiotics all the time, which has got its own really long list of side effects, I do not recommend that, is give you some vaccines to help the body boost its immune response to the bacteria that could cause you the OPSS. And people have looked at being on the long-term antibiotics. There really isn't a reason to do that, and the side effects of colon superinfections, malabsorption of things, they're going to get you in trouble with Julie if you're on those things all the time. So nobody in the States that I know of does that anymore. That's sort of an old school thing. Way back in the dark ages when I was a medical student, they talked about keeping people on low-dose penicillin all the time. But those days are gone with the rise of better vaccines for splenectomy patients.
Thank you for your questions. Are there any on nutrition or fitness?
We have one other question over here.
Sure.
I had my spleen removed, and they did recommend that I take vaccines, but then they recommended that I not take them while I was on chemo. And I have been on chemo, different types, for the past 6 years. So how do I get those vaccines in while on the chemo? What
You
do
can
I-
actually take those while on chemo, and the reason is the vaccines you don't want to take when you're on chemotherapy are live virus or live bacterial vaccines. These are killed bacteria vaccines, so they should be safe. Having said that, you probably need to put them in between cycles. Don't get them when your white count is low. So probably like a couple of days before you get any specific cycle. And this kind of thing you can talk to your medical oncologist about.
Any other questions?
For the other half of the room,
Got one over here.
or recommendation for caregivers.
I think you heard me.
The question was on caregivers.
Recommendation for caregivers. I'd say marry a good patient would be the first thing. Not to be flippant about that. It is a team thing. As you heard Christy talk about her ordeal, as well as Sheely talk about his ordeal, and you've seen your colleagues around here. Have a good team, and really think consciously about selecting a good team of people. And sometimes it is those folks who have been closest to you forever, and sometimes people just pop out of nowhere and become part of your team. You've heard Cassie talk about exercise, Julie about eating well, Katie Duckworth talk about sleep. Of course, try to do those things as best you can. And also, as a caregiver, I think celebrate the fact that you care for someone enough to sacrifice. I grew up with my mother talking about sacrifice. There are some sacrifices that you make. You heard about Christy's husband who slept on the bed in the room with pneumonia. Not recommended caregiver activity, but for him it probably was uplifting. So there are some times when the caregiver does sacrifice. So take care of yourself. You've heard those things, but also recognize that what you're doing is it's a duty and it's an honor to be caring for your loved one, whoever they may be.
Okay, so I do give some advice to caregivers around feeding, and I think it's just really important that caregivers have like a boundary so that, because sometimes you feel like you have to feed your loved one and they have to eat the food that you make, and if they don't eat it, then you're not doing a good job, and then there's fights, and we don't want more, difficulties. And so what I tell the caregiver is that you do a good job simply by reminding them, hey, you haven't had anything, can I get you something? Or preparing the food, and that you don't have to force them to eat it in order for you to congratulate yourself for doing a good job. So that's where I kind of draw the line. You don't have to force feed and fight over it. You offer it to them. If they don't feel like eating it, they're not feeling well, that's okay, you've still done a good job.
I'm not on the panel, but I'm going to crash on this one as a
You're an
caregiver.
honorary Pember Mantle now.
I get this question a lot too, and I go back to, I think it was during my husband's first HIPEC surgery. My parents lived 15 minutes away from the hospital, and my mom is a therapist, and it was a particularly horrible day at the hospital. And my mom said, when the airplane goes down, you put your mask on first, and then you help others. And she said, you have to take care of yourself. You cannot take care of somebody else if you don't take care of yourself. I have told so many people that, and it's just so simple, but it's really important. Secondly, ask for help, but not only that, you have to be specific. You have to be specific. You have to figure out what you need, find the right person to ask, and ask specifically. I've had some other friends going through some health issues recently, and I took that knowledge, and it was amazing, just saying, you do this, because people want to help. They don't know what to do. You got to figure out what you need, ask specifically. I think it really helps a lot. So.
There's a question over.
Dr. V did my surgery 2 years ago, and at that time, before I was diagnosed, I was the healthiest person I knew. And we have yet to understand, do y'all have any idea what causes this? We also have children. Is there anything we need to be concerned about with them? Is this hereditary? Any information you could give us on that?
Sure. been working on that for a while. So I can tell you, some of the answers are actually pretty easy. Is this a hereditary tumor? Almost never. Almost never. We've got 800 and something patients in series. We've got one father-son and one uncle-nephew combination in 800 cases. So this is not the kind of thing you'll see in a breast cancer family where you see generation after generation after generation. This is not that kind of a tumor. What are the risk factors for cancer of the appendix? And the answer is, nobody knows any. And what I usually tell patients who ask me this question, and you're not the first patient, and I think you won't be the last, and I'll give you the following very unsatisfactory answer, which is, what causes this? Bad luck. Sometimes, and you've seen people who have heard me say this, sometimes bad things happen to good people. And in America, we live in and there's lawyers all around here, so I have to be careful, but we live in a tort system where everything has a proximate cause, and this usually doesn't. The proximate cause of somebody's appendiceal cancer could have been a solar flare, and some radiation went rolling through the earth through a hole in the clouds, and it knocked a couple of atoms loose on your DNA, and next thing you know, kaboom. So what caused it? The solar flare? I don't know. And the truth is, we don't know. And some of these things just happen. So can I tell you what genes are active that cause these tumors to grow? Yeah. Oh, I've got a laundry list of genes that are active. Is there something you can do to keep them from getting active? No. There's nothing that I know of yet. So I would love to tell you there's a way in terms of prevent things. If I could make you feel better, say this is not usually an inherited cancer, I hope that helps you some. The exception to that is over the long haul, anybody who's had a GI cancer of any type, and this is not specific for cancer of the appendix, but any GI cancer, you probably want to get your children screened at about the same age, or 5 to 10 years, before you were diagnosed, just to screen for other primary tumors. I told you that these cancer of the appendix are frequently associated with other tumors, particularly colon polyps. Colon polyps are associated with other cancers. Those can be inherited. So the appendiceal cancer per se usually isn't, but there is some risk. But again, this is not the kind of thing that you usually see in some families where you've got an inherited predisposition, so it's generation after generation. We just don't see that.
A quick follow-up on that. When you say screening, do you mean colonoscopies? Because as I understand, colonoscopies don't typically identify this.
Yeah, colonoscopy is a good idea if you're looking for colon cancer. It just will not find appendiceal cancer more than 3% of the time, even when you have it. So there is no screening program for cancer of the appendix. I mean, I wish there was. It would make my job a lot easier. Oh, my goodness. But there is no screening program for this.
I'm sorry, but then how do you have your children screened 10 years before your age?
Well, you're not screening them for colon cancer. You're screening them for other bowel cancers. No. They don't screen people with CAT scans. I don't recommend any screening for cancer of the appendix. There's no data for it whatsoever, and I'm not sure how you would do it, to be honest. I'd love to tell you there's ways to screen your children for this. They need to be screened for all kinds of other things, and you want to do all kinds of other healthy habits. You're probably better off eating a healthy diet. It's probably as good as anything else. Which is, I know, that's not the answer you want, because you want to be proactive, but there's just nothing proven to work yet.
I am hitting close to 15 years now. Thank you very much.
Congratulations.
Thank you. And you did pronounce me cured, so I'm going to hold you to that. But my question is, I seem to have continuous digestive issues, if you will. There are times when I can eat something and it sits just wonderfully. I can eat the same thing 2 days later and it just goes straight through my system. Is this something that's fairly typical? Do I have something else to worry about?
I mean, I think a lot of people do deal with that, and it could just be, it's hard to know what it is. So sometimes we'll say, well, you keep a food log, right? Which is kind of a lot of work and you might not see a correlation. But I do think that it is helpful to, if you have sort of these recurring issues, that you keep a food log, and then it helps you identify if there is something. If there's some evidence, so if it's kind of like irritable bowel, that you may be able to sort of address it that way. If it's, and you can't quite tell if it's a food item, there's a GI diet that helps some people with irritable bowel called FODMAP, FODMAP. You know, I think it works for some people and it doesn't for others, but it does help to at least classify foods into groups that maybe if you had like a lot of them in one day, it might contribute to more issues. But sometimes it's just kind of, today didn't, yeah, exactly, the way it is.
Yeah, there doesn't seem to be a rhyme or reason to a lot of it. Thank you.
May I ask a question also? When they were talking about screening, you mentioned the markers, the C markers. Is it reasonable to, if you have physicals on a routine basis, they take blood to check different things, is it reasonable to look for those markers to see if there's a change there as any indication?
Interestingly, people have looked, these markers are not specific to cancer of the appendix. They're common to a whole bunch of tumors, and people, there have been studies which have looked at using them exactly for that, to try and use it as a screening test to look for cancer, and they haven't been successful. But each one of these tests, if you use, they're good for following cancers when you have them. If you use them for screening tests, they're full of false positive results, particularly when the numbers are pretty close to the normal level.
But I mean, if there was a trend.
You can do that. The problem is the rate of having a positive number is so low that most people aren't going to recommend it. Because remember, we have a population in this room of people with a rare disease. And if you talk about screening the entire population, the relative good of that kind of screening is going to fall off when you start working up the false positive. Because if you see something comes up a little bit, and the truth is if you smoke, those numbers are going to go up. If you walk by smoky flames or outside camping a lot and you're breathing in a lot of smoke, those numbers can go up. So there's a lot of reasons for some minor fluctuations, and if you start looking too hard at those numbers, particularly when they're at relatively low levels, the workups for the false positives are going to outweigh the benefits that you get from the few you actually find.
Okay, so I just wanted to clear up. You said that we could have our kids screened 10 years before our onset, but what screenings are you recommending?
It's bowel screening, so you should do colonoscopy, and it depends. Again, I can't use a blanket statement for everybody. You know, you look pretty young over there, so you probably got diagnosed when you were 7 years old or something. But so in general, and this is true of colon cancer too. You know, so in terms of screening children, I would use the colon cancer recommendations, which are based on much larger numbers. And I've spent all morning telling you that colon cancer is different than appendix cancer, which it is. However, they do share some characteristics. You know, so what I recommend screening. Now, if you were diagnosed when you're 25, don't start screening your kids with colonoscopy when they're 15.
We're going to have one last question.
Yes, my name is Myra, and I'm going on 16 years. And Dr. Levine is one of the best in the nation. Mine started out with I went to have my carotid artery checked. I'd had surgery. And the doctor called me at work, and he says, "You have ascites." I said, "What's ascites?" He says, "You have fluid where it's not supposed to be." Well, they didn't know what to do with me, so they sent me to the Baptist. And this is before any of this was built. But my question to Dr. Levine is, I always have had my CEA rate checked, and last year it was 7. What should it be? I haven't had it checked this year.
Normal level for a CEA level is 3 and it depends a little bit on the laboratory where you get, for rough numbers, less than 3. If you're a smoker, less than 5. The truth is, if it's between 5 and 10, that may be a false positive. So it's the kind of thing you have to check it. If you're feeling fine, and you look like you're feeling fine from here.
Most of the time, but lately it's something's going on. So I just want to know if I need to get it checked again.
I probably, if it was 7, I might get it checked again in a few months. This is not the kind of thing you have to do all the time. And if it consistently continues to rise, particularly if it gets over 10, probably it's time for another scan at that point.
And one more thing, I want to thank everybody here because this was not even built when I started coming over here. And I came over here for 10 years to see this man, so going on 16 years, and it's wonderful what they have here now.
Yeah, thanks for putting up with me for 17 years.
Hi, my name is Gary Ramsey. I'm also a 15-year survivor. 15 years and 8 months to be exact. The soreness, I'm 15 weeks in on my last surgery. The soreness is still pretty good in the lower abdomen and where they put in one of the ports on the lower right side. Is that clear?
After 15 years?
No, 15 weeks. I just had a surgery 15 weeks ago.
Oh, 15 weeks ago?
Yeah.
If it was 15 years ago, the answer is definitely no, and you're stuck with it.
No.
15 weeks, it tends to get better over time. The good news is that if you still have some soreness after that kind of surgery, after 15 weeks, we finally have an exercise. Question?
And I kind of want to address the adhesions too, because it's the same thing. If you have soreness in the skin or in the scar or any of that, you can just kind of put your hand on the scar and just stretch it. You can stretch it left, right, any of the o'clocks, and find out which way it's tight and kind of pull on that for about 30 seconds and hold it. That should improve it. Also doing the stretching, like leaning the knees to the side, if that feels tight, and just walking and moving is going to help all that improve as well.
Yeah, I still have trouble, like y'all were talking about earlier, about getting out of bed. I have to roll to my side.
Right.
And then actually push up on the nightstand to get myself out of bed in the mornings.
So you probably need to start with some of those early exercises where you do the abdominal sets, where you're just kind of making a muscle in your tummy, holding it and working on that, and then see if you can do like the pelvic tilt where you kind of flatten your back against the bed and see if you can slide that foot back and forth. If your back starts to arch, you're just really too weak and you need to stay with the abdominal sets initially.
Okay. All right. Thank y'all.
Mm-hmm.